Seattle has been known over the course of the last century for so many things, for aerospace, for timber, for software, for coffee. But I would venture to say now at the start of the 21st century, this city is going to be known the world over for the mark it's making on philanthropy and global health and development. And here today to share with us her perspective on the ways in which we need to change our approach to development is UW faculty member, physician, remarkable change maker, and Director of New Initiatives for Health Alliance International, Wendy Johnson.
Thank you. The campaign to eliminate smallpox was both one of the greatest triumphs and one of the greatest tragedies in the history of public health. Of course, the fact that smallpox was eliminated was a great victory of technology and medicine. 122 million lives were saved. And here are the directors of the global smallpox eradication campaign, and part of the credit for that effort comes right from Seattle, part of that expertise. One of the heroes is Bill Foege, who's pictured there in the middle. The tragedy came from the fact that the day after the last vaccine was administered, all of that effort essentially evaporated. Nothing was left behind. The campaign was innovative because of the technology and the way it was delivered. Focusing on outbreaks and using ring vaccination approach was revolutionary at the time. But because of the urgency, the expertise was supplied largely by Europeans and Americans. Poor countries provided the cheap labor. And so when it was over, the experts packed up and went home. And we perpetuated a model of colonial humanitarianism that still persists today. There was no effort to build local capacity and infrastructure. We went back to our scientific institutions and our academic institutions, and we waited for the next epidemic. And we didn't really have to wait very long. This was the last naturally occurring case of smallpox in 1975. And about that same year, HIV was gaining hold in human populations in Africa. And there's growing evidence that treatment and vaccination campaigns for other tropical diseases like sleeping sickness may have hastened the spread of HIV through the use of unsterilized or improperly sterilized needles. Yet another inadvertent side effect of benevolent colonial intentions. Our response to HIV, though, was impressive once the voices for human rights won out over the naysayers. And it was difficult because one of the biggest naysayers at the time was none other than the head of USAID, who thought that Africans probably couldn't tell time well enough to be able to know when to take their pills. The new wrinkle was that donors, especially the US, decided to fund hundreds of international nonprofits to deliver these massive treatment and prevention campaigns. So the consultants shifted to these nonprofits, but still the expertise was largely flown in. I was in Mozambique working for one of these nonprofits during the most impressive years of the HIV treatment scale-up. And largely due to the hard line of the Mozambican Ministry of Health, things ran a little bit differently there. The Ministry of Health insisted that we roll out HIV treatment in public sector health clinics that were already existing at the time. And by working through the public sector, we grew the number of HIV treatments in Mozambique, or HIV treatment clinics in Mozambique from 2 in 2004 to 64 today. But still there was a number of international nonprofits that insisted on setting up their own parallel programs. And I saw this most dramatically in the effort to prevent transmission of HIV from mothers to children. And here is a woman with HIV who, she was able to get medications to prevent her child from getting infected because it was delivered as a routine part of her regular prenatal care. But this is the exception rather than the rule in Africa. Even in Mozambique, where 70% of women get prenatal care in the public sector, most international organizations still insisted on setting up their own separate HIV clinics. So after taking off a day, a precious day of working to provide food for her families, a woman was told she had to take another day, go to another clinic to get tested or to get the pills to protect her children. In a lot of cases, that just didn't happen. It was just too difficult. So that's, as a result, we're still far behind in getting preventive treatment to women to protect their children. Only about 20% of women in poor countries get HIV tests during prenatal care. So this sense of too few successes, or that as soon as we take care of one disease, another one just crops up to take its place, leads to an aid backlash. Jesse Helms once famously said of aid to Africa, it's like sending money down a rat hole. And William Easterly talked about the tragedy of spending $2.3 trillion over the last 5 decades and still not managing to get 12-cent medicines to children to prevent malaria deaths or $4 bed nets to families. The West is not stingy, it's ineffective, he said. And the reason we're ineffective is that international aid is still based on the model of charity. It's kind of like providing handouts to the homeless. It might make you feel good to give $1 to the guy in the corner today, but tomorrow that guy will probably still be there. That's because charity is not about solving the problem. So what's required is a paradigm shift from colonial era charity to a model of solidarity. But we have a pretty far way to go. This is a result of a study from a group called ActionAid that estimates that only about 50% of the aid that we give is what they call real aid. It gets to where it's intended, used as it's intended. The report is especially critical of money spent for foreign consultants and cites the case of Cambodia, where 740 international advisors cost $50 to $70 million, and that's as much as the entire country's civil service sector of 160,000 people. And another set of handcuffs on poor countries comes from the constraints that the IMF puts on indebted countries, making it very difficult for poor countries to increase their public spending, to hire more doctors or more teachers or more nurses. And this perpetuates the reliance on technical assistance that we see today. And all of this comes when severe shortages of health workers are making it exceedingly difficult to get further advances in treating HIV or TB or malaria in poor countries. Mozambique has fewer than 3 doctors for every 100,000 people. Now, just imagine how easy it would be for all of you to get health care if we only had 17 doctors in all of Seattle. All kinds of doctors, including emergency room doctors. In Washington, we are becoming a center for global health. But we're very big on technology fixes and on magic bullets. And it's very difficult to have a model of solidarity when we're focused on how much the business of global health can benefit our own local economy. But, you know, what's wrong with that? After all, hasn't technology saved millions of lives over the years? Well, yeah. But this is what happens. There you go. This is what happens when you worry just about technology development and not about reducing disparities in how that technology gets to people. The most well-off will take up the new intervention or technology first and more completely. They'll have better access and they'll reap the benefits more completely. And then finally, it'll trickle down to the few of the poorest, and some of them will get advantages. You end up benefiting the poor a little, but increasing the health disparities in the end and doing far less good than is possible if you focus both on the technology and on building local public institutions to deliver that technology effectively. So what would an aid policy based on solidarity look like? Well, perhaps we'd invest just as much in training laboratory technicians as in developing and buying new lab equipment. Right now, in much of Africa, there are scores of diagnostic equipment and laboratory machines that are underutilized because the skilled staff to operate them just don't exist. These are very long-term goals. It takes years to train a doctor. So we need cooperative joint funding mechanisms that give dollars directly to local governments and concentrate on rebuilding the public sector with adequate oversights and protections. But wait a minute, we have a program to do just that. It's called the Global Fund. But we're not funding it. In the meeting last week to set global commitments to the fund, they failed to reach even the most austere goals. So now, over the next 3 years, no new projects can be funded, and it'll be difficult for the fund to keep up with just the current commitments. In Seattle, we have all the ingredients necessary to create an amazing marriage of solidarity and technology. We all know the experts in technology development here, like Gates and Path and Seattle Biomed and the Hutch. But less well known is that we also have groups like iTech and Health Alliance International and Agros and Village Reach that are working in the spirit of solidarity. Imagine the truly innovative impact that Seattle could have if we could forge partnerships between the experts in technology and the experts in delivery to the poorest and most marginalized populations, and do it on a global scale. No one's ever done that before. And maybe we could even get this midwife and her colleagues an electronic Doppler machine that's cost-effective rather than this 18th century technology that she's using, a wooden fetoscope, to listen to a pregnant child, a pregnant woman. If we could apply the idea of solidarity to our own work here, we truly could change the world. Thank you.